Welcome, everyone, to this presentation, Safety Concerns for People Living with Dementia. The goal of this presentation is to talk about general safety issues and also to drill down because there are certain situations that are more prevalent in one stage versus another, or you may see more in one type of dementia than in another type. So I want to talk about the different types of dementia and unique safety concerns, but first I want to go over the stages briefly. People always ask me in clinic, what stage is my family member in? And there are, depending on which researcher and which site you go to, some places say there's 7 stages, some have 7, but then some of the stages are broken down in A, B, and C. And the problem with trying to stage a dementia is depending on the type of dementia, you may see different problems at different stages. So, for example, somebody with behavioral variant frontotemporal dementia, in their mild stage, they are able to recall information and events, but real problems with impulsivity and empathy and critical thinking. Whereas someone in the mild Alzheimer's stage, you won't normally see the impulsivity, but you will see problems with recall. So that's where it gets tricky trying to put people in boxes. And these stages were developed for researchers, and I use staging in my research studies, and most of the staging instruments were developed using participants who were more affected by Alzheimer's and vascular and not necessarily other dementias. So that's why it's hard to put people in little boxes. But this is just a general way to classify. So I tend to use mild, moderate, and severe. And mild, someone with mild dementia, and I hate that word mild because it's like saying a mild amputation. There's nothing mild about dementia, regardless of type. But clinically, people are considered mild because the memory and cognition problems, they're not readily obvious to someone who is not well known to that person, who doesn't know that person very well. This is a situation where if you have a physician or provider who really doesn't know the individual and they're performing a very superficial interaction. Hi, how you doing? What do you think of the weather? Most people with mild dementia, they can respond in a generic way so that you think everything's fine if you're not paying attention. And if you engage the person for a brief time, the conversations seem appropriate. But the longer you engage with the person, the more you may hear repetition, the same thing being said over and over again, or the same joke. And therefore, the more prolonged you are interacting with them, the more you see the issues. These individuals are also able to perform their basic activities of daily living, which is self care, and most domestic activities of daily living, such as chores in the house and the yard. They can use the remote, they can use appliances. Where you may see problems are in the more uh, abstract activities that require more what's called executive function, things like planning a grocery shopping trip where they have to have a list and they have to get stuff, or activities such as assembling paperwork for taxes or managing finances. Yes, these people may be able to write out a check, but you may find that they are either not paying the bills or they wrote 3 checks to the same person. So that's your mild. Safety concerns in the mild stage can be delirium, especially with urinary tract infections. Because what happens is people who develop infections, once they have a dementia diagnosis, you may see confusion as the primary problem, not necessarily back pain or abdominal pain. In the mild stage, this is where you start to see them getting lost when driving in familiar places. And this is also an issue with for financial exploitation because they can write a check, but they forgot that they already paid the bill, like I said a second ago. Now, the moderate stage, the moderate can be is the longest stage people are in, and clinicians will sometimes separate moderate into three substages. So the mild moderate, these are people who have left the mild stage and they just started in their moderate stage. So you often see conversation that becomes increasingly vague. It doesn't have a whole lot of substance to it. But in the case of vascular Alzheimer's and usually Lewy body, the social cues remain intact. These are people who know to pause. If you're talking, they stop talking, they'll make eye contact. Someone with behavioral variant FTD, the social cues go out the window, and you're going to see people who are very intrusive, don't let you finish a sentence, and engage in inappropriate comments and humor, inappropriate for the situation, humor that is sexual in nature or just rude. Now, the other pieces with the mild moderate is with the Alzheimer's vascular Lewy body, you see problems with short-term recall. And now they're having problems with the domestic activities of daily living, like using the microwave, using appliances. This is starting to become a problem. In the middle moderate, they are able to perform their own self-care activities like brushing teeth, bathing, dressing, etc., but they're having problems with appliances. This is a situation where they turn on the oven, leave it on, put foil in the microwave. And at the middle moderate, this is a time when being left alone may not be a good idea. I hear family caregivers all the time who say, I can leave him alone for an hour. And I will say, great, but what if he needs to call you or call 911? Can he operate his smartphone? Can he find his smartphone? Can she use the landline? Does she remember where the landline is? And if they can use the telephone, they can call 911 or at least call you, then, oh, okay, you might be able to leave them alone for an hour or two. But the middle moderate often catches family caregivers unaware because the decline happens so gradually that they may not be realizing the person can no longer do some of the tasks they could do earlier. Because sometimes what you get is you get the person living with dementia who says, I don't want to do that, or I don't need to do that. So they're telling you they won't do it, but in reality, it's possible that they can't. So that gets a little tricky. The late moderate, you start to see them having problems with their basic self-care activities. This is where you notice they might be wearing the same stained pants over and over again, or they are putting on the same shirt 3, 4 days in a row, or they're putting stuff on maybe backwards. One of my family caregivers knew something was up when she was taking care of her grandmother, and one day grandmother walked out of the bedroom with the bra on top of the shirt. And that at that point we knew she was toward the end of moderate, heading toward severe. Some safety concerns at the moderate stage are neglect. And I don't mean you're neglecting them. No, that's not what I'm saying. What's happening is they may start refusing care. oftentimes we want to give our loved ones autonomy. We want to listen to them. We want to engage with them. And it's funny, I was talking to someone today who mentioned that one of the hardest things for her to grasp is as her mother went down the dementia pathway, she kept wanting to have the old conversations back. She wanted to tell mom what was going on today, what was going on with the grandkids. And mom couldn't follow this conversation. And instead, they had to keep the conversation somewhat bland because mom would keep saying, but I want to go back to my house. And they had sold her house and she was living with my client. But my client kept wanting to explain to mom what was going on. And that was just getting mom more and more irritable. And the other issue that I'm going to talk about more on Monday, because I'm doing another one of these on Monday. And I have another person who knows, but nobody else knows yet. Surprise! That's your bonus for showing up. But one of the topics I want to hit on Monday is I talk a lot about care refusals. I was challenged today with someone who said, here's my situation. I want to bring in help for my dad, but my dad will only let me touch him. I'm the only one who can provide care, and I can't do it. And I said, wow, I don't always think about that. So I'm going to talk about that on Monday. And I also, when you get into care refusals, I do talk about the strategies to minimize care refusals that I will talk about in the class that I'm giving. And elopement and wandering is a problem because supervision needs change over time. And people with dementia can also become combative because they see care as a threat. So the severe, that's pretty easy to recognize. This is unfortunately the end where the person living with dementia is dependent upon you for everything. They need you to help dress them or to dress them. They need you to supervise and give them a bath or shower. They might be able to feed themselves, but over time, they have trouble using utensils, start to use finger foods, and at the very end, you are feeding them. And this is where the swallowing can become an issue. And I usually tell family caregivers when swallowing becomes an issue, this is the time to maybe talk about hospice and or to consider, am I going to keep them home with hospice or do we need to place them in another level of care? And I also get questions about feeding tubes. And really, feeding tubes do not improve the quantity or quality of life. It's a surgical procedure. And you can still choke and get pneumonia because even though you're putting food directly into the stomach through a tube, people can regurgitate that the liquid food in the stomach and they can inhale it. So you can have aspiration pneumonia even with tube feedings. They don't. The chance of aspiration pneumonia doesn't go away. And now you have a possibility of an infected area. And sometimes people living with dementia get confused. What's this thing? And they pull it out. And now we have a trip to the ER to put the feeding tube back in. One big safety concern here is when you help them transfer, falling or dropping during transfers. Now, I want to talk about two big issues that relate to safety that pop up in the dementia journey. The first one's driving. And a lot of people with dementia have something called anosognosia, which is a fancy word for I'm not aware of my problems. I forgot that I forgot. And also, you can have people with visual spatial problems. What I do in the clinic is I ask people to draw a clock. And if they cannot draw a clock properly, their visual spatial abilities are being compromised. I'll also ask them to draw a 3D cube. And I see visual spatial problems happening fairly early in Alzheimer's, Lewy body dementia. If people have people with Parkinson's disease dementia usually aren't driving because of the movement problems, but they do present with visual spatial problems a little earlier on and then the cognitive issues. But people with frontotemporal, I noticed the visual spatial problems hitting more when they seem to hit the moderate stage. And now everybody is different, but I'm talking in general. With driving, you may need to curtail driving early in people with behavioral variant FTD because the problems that show up are rage and impulsivity. These people can pass a driving test. If you give them a memory test, they may score perfectly. And that's because most memory tests that you do in the office are real light on assessing judgment and executive function. The Montreal Cognitive Assessment does the best one, but most clinicians don't give it because it's a little bit lengthy. But I've had situations where we did have to take away the keys because the person had such incredible road rage to the point they were trying to run people off the road. I always ask 2 questions to figure out if a person living with dementia should be driving. And honestly, if you answer no to this question and to the next question, regardless of dementia or not, the person shouldn't be driving. And that's a source of a little bit of humor in my family because my son, Mark, I've mentioned him in the podcast. He's a state trooper in Florida. He has told me for the longest time that I probably shouldn't have a license. And he's probably right. I don't think it's dementia. I just think it's sheer, incompetence. I learned to drive in Philly and I'm just leaving it there. But I ask people 2 questions to determine if a loved one should be driving. And the first question is, do you feel safe being a passenger while your loved one is driving? If the answer is no, they shouldn't be. The second question, because sometimes I have people who say, yeah, and I say, all right, would you let your child or grandchild be a passenger while your loved one is driving? If I get a hard no, then the answer is they shouldn't be driving at all. Another important safety issue that comes up a lot is fall prevention. And everybody is at risk for falls, but for people with Lewy body, Parkinson's disease, dementia, these people tend to have motor issues as well. So they are most definitely, like early in the disease, you want to be fixing up the house to prevent falls. Now, Alzheimer's disease, the fall issues tend to start emerging around the mid-moderate. And this also depends too if they have other physical problems like arthritis that may be interfering with their ability to move around. Medications are a big issue. We give people with Alzheimer's and people with Lewy body and vascular, we give them a medicine called donepezil, also known as Aricept, which is appropriate to get in the early stages, or I should say the mild stages of dementia. And donepezil can slow down the heart rate and can cause the blood pressure to be a little on the low side. And if my heart rate is a little on the low side, when I'm sitting, if I were to stand up, my heart rate would immediately increase to compensate for gravity and the fact that my blood might be pooling a little bit in my lower legs. So if I stand up, my heart rate and my blood vessels would constrict and they would adapt to my change in position so I don't feel dizzy or lightheaded. If you've ever squatted in front of the fridge or crouched down, like to look for something, you were in a crouched position for any length of time, and then you suddenly stood up and your head swam a little bit, that's because your position change happened too quickly for your heart and your blood vessels to compensate. In people who are getting Aricept or donepezil, that problem is increased. Some people are very sensitive to Ariset to the point where we have to take them off. We have to drop their dose because they're what it's called postural hypertension. When you change positions and your blood pressure drops, other people take donepezil. They might as well be taking Tic Tacs. It's not bothering them at all. But it's something to be aware of. Now, if you have someone who's also taking blood pressure medication, you have to watch because the blood pressure medication may slow down the heart rate and dilate the blood vessels. And if you also have a situation where they may not be drinking enough fluid, you're going to see a drop in blood pressure. I'm going to talk about that in a second. So to prevent falls, when when a diagnosis happens, and honestly, this isn't a bad thing to do for all of us as we age, is to get rid of throw rugs, mats, declutter, watch the shoes. Slippers and flip-flops are a fall risk. You want shoes with a nice sole, a nice rubber sole that doesn't slip, so they are less likely to trip, and shoes that offer support. I often see people who might have some swelling of their feet and ankles, and so they can fit their foot into the shoe, but they can't fit their heel. So they start wearing regular shoes, almost like clogs or flip-flops, and that's a disaster waiting to happen. Hydration. Everyone always says to me, how do I know if my loved one is getting enough fluid? If they pee and their pee is light to medium yellow, they're doing okay. When the pee starts to turn dark yellow, and if it smells strong, they need more fluid on board. And this is the summer, and hydration can be a real challenge. Popsicles and high wood fruit like watermelon and cantaloupe are some sneaky ways to sneak fluid into your loved one. And if diabetes is an issue, then you can make your own popsicles with fruit juices, or you can get popsicles that are sweetened with artificial sweeteners. I like to do what I call paused position changes. And what I mean by this is if you are seeing that your loved one may get dizzy when they change positions, you want them to do it more gradually. So instead of getting them up out of bed quickly, you may have them go from laying down to sitting up and sit on the edge of the bed for a minute, and then go from sitting to standing, and you are there just to make sure they're not feeling dizzy and unsteady on their feet. And if you believe that your loved one is complaining of dizziness, it might be having some trouble with position changes and their blood pressure fluctuating. You may want to get yourself a blood pressure machine, learn how to take a pulse, and keep an eye on their pulse and their blood pressure to make sure that it may not be too low, and that's the cause of the problem you're having. And that's a conversation also to have with your primary care provider. I wanted to talk about your safety. And the reason why I want to talk about your safety is because I always talk about the safety of the person living with dementia. I don't always mention that you have to be careful. The person living with dementia may see your regular caregiving activities as a threat. And I've talked about that in other podcasts and in other seminars. But to recap, you have something in the brain called an amygdala, and that's the threat detector. And as dementia gets worse, the amygdala still functions, but the parts of the brain that tell the amygdala, yes, that's a threat, no, it's not, those parts go offline. As the dementia gets severe enough, the amygdala itself also starts to shrink. But what you have is you have a situation where the amygdala is like the smoke detector, and it's going off constantly. In my house, when the smoke detector goes off, it's either the couch is on fire or dinner is ready. And when I hear the smoke detector, I have to stop and look around and determine, is dinner ready, or do I need to grab my dog and cat and leave the house? your other parts of the brain, when they receive signals from the amygdala, the other parts of the brain process the environment and tell the amygdala, hey, no, the person's just trying to help you get into the shower, or, and you're fine. But if those parts go offline and the amygdala keeps sending the alarm, the other parts of the brain go, oh, snap, we're under attack. And they may try to strike out at the person giving them a shower. Refusal behavior can range from verbal, no, stop it, leave me alone, to them trying to leave the environment, to them striking out at you. And I have a bunch of strategies you can use to prevent and manage care refusals. And I have something on my dementia hacks, 15 ways to help people living with dementia who need help. That's a free resource. And most people who have signed up for my newsletter have access to that. So if you're listening and you don't have it, let me know and I can add you to the list and I can send it to you. There's also times when people living with dementia may be highly irritable, and that irritable can then progress to anger and to rage. You see this more with people who have behavioral variant FTD, but it can happen in any of the dementias, especially if the person you're caring for may have had a short fuse pre-dementia and the fuse is non-existent with the dementia. And I talk about strategies to communicate without triggering, such as saying, okay, and then proceeding with what you want to tell them, or I hear you, and let's go over here. I dive deep into these strategies in my Confident and Competent Dementia Caregiving course, and I also have gone deeper in this in other presentations as well. Then you have the jealousy and paranoia delusions. And this can get dicey because if the person you are caring for thinks you're trying to hurt them, or if they think you're sleeping around, that may cause anger and rage. If you are in a situation where the person you are caring for can be volatile and you are concerned about your personal safety, I would recommend having an escape plan. And any part of a good escape plan is having your supplies in a safe place, perhaps at a neighbor's, perhaps in your own personal vehicle, assuming you have the keys to that vehicle. But I would recommend a overnight bag with copies or originals of important documents like ID and passports, a second cell phone, something that is like really cheap, one of those maybe pay as you go that's already been activated, a contact list of your important numbers, because I have all my contacts in my iPhone. So if I get separated from the iPhone, I don't know how to get in touch with these people. So one of the things I do is I upload a lot of my stuff on the phone to either the Apple Cloud or to Google Cloud. So if I ever were to lose my phone or I'm in a position where I can't access it, I can get my contact information from a cloud somewhere. Having spare house and car keys, a change of clothes, and some credit cards, because I have everything in my purse. But what if I'm caring for a family member and they get between me and my purse? I got to roll out the door. That's why it's not a bad idea to have a bag of this stuff somewhere outside of the home that you can gain access to. Now, I want to talk about safety issues for people with vascular dementia. Sometimes people sustain a symptomatic stroke. They had a stroke. And there is something called anosognosia for hemiplegia. And you're thinking, what in the world is that? Many people who have experienced a stroke tend to have weakness or paralysis on one side of their body. Maybe it's just their leg, maybe it's just their arm, maybe it's both. It depends on where in the brain the stroke occurred. And I had a doctoral student. She's now graduated. She's Dr. Bird now. And when Dr. Bird was my student, she was working as a nurse in a rehabilitative hospital. And she noticed that she was doing fall assessments on everybody, but the fall assessments were worthless. You had people who were assessed as low fall risk, and they were falling just as much as the people who were categorized as high fall risk. And she did a study. Her first study was she looked at people in her unit and compared the people who fell against the people who didn't fall. And big shock, there was no change in level of confusion. There was no change, there's no difference, rather, in either group based on level of confusion. The people who fell and the people who didn't fall had the same amount of cognitive ability. It wasn't like the people who were falling were more confused. They weren't. The people who fell did not have any more severe stroke symptoms than the people who didn't. And she did what's called a multiple regression with the two samples, and we couldn't find anything that was different. And finally, I said, I bet you there's something else that we're missing. So the two of us were sitting in front of PubMed one day, and I remembered that we had something called anosognosia that I was talking about with my people living with dementia. And so I think I typed in anosognosia and stroke just to see what would happen, because I said maybe they're just not aware of their problems. And then this term, anosognosia for hemiplegia, showed up. And it turned out that it's known by a small group of neurologists, but it is not known at all in the nursing literature. So she wrote this article and got it published, and she's publishing her dissertation. She went into a local rehabilitative hospital, and she was collecting data until COVID shut her down. But she wound up enrolling about 15 or 16 people. And she had an instrument that she could ask the people about what could they do or not do. And if people could say things like, yes, I can walk, yes, I can do stuff, and she asked the nurse or the physical therapist or their family member the same questions, the family member, the nurse, and the physical therapist were all saying things like, no, she can't move her left side. But the people who had the stroke were saying, yeah, my left side works just fine. They weren't in denial. It felt like their left side could work. So what she found was this anosognosia for hemiplegia was present, I want to say, in 95% of the people she enrolled in her study. The current literature says it's only maybe 30 to 50%. So that alone was significant. So one of the theories we have is that we're not assessing for anosognosia, and therefore the people living with dementia, or excuse me, the people who've had a stroke, they are getting up out of bed because they think their paralyzed side works, and it doesn't. So someone with vascular dementia, I'm wondering if they may also have the anosognosia for hemiplegia, and therefore might be trying to, you're telling them don't get out of bed, you can't walk, and they go ahead and do it anyway. I wonder if that's a piece of it. Now, safety issues for people with behavioral variant frontotemporal dementia, and I spoke a little bit about this earlier, but these are people who are very impulsive, which means they can be aggressive. They can have very quickly changing moods. They are disinhibited. Most times, the disinhibition is around food consumption. We call it hyperorality. And these people may decide to eat food from other people's plates. They may sit down and eat, eat 5 pounds of candy in one sitting. And that can be a problem if they're diabetic. And some of the sexual disinhibitions can be problematic because it can be anywhere from flirtatious behavior to overt advances. And this can get them in trouble in certain situations, especially if the object of their behavior is someone who is maybe underage, and now we have a problem. People with behavioral variant FTD can often have false beliefs known as delusions that the grandiose, that they're highly important, or delusions of paranoia or persecution. And that may result in them refusing to eat or take their medicines because they think you're praising them. Another issue is apathy. And there are neurological reasons for the apathy. There's parts of the brain that control interest. And if those parts of the brain start to shrink, they have no desire to move or motivation to do things. And these are people who will literally sit on the sofa for days and not bathe, maybe not eat correctly, won't change their clothes, and that can put them at risk for, dehydration, put them at risk for sores because they're not keeping themselves clean, they're not changing their clothes. Lewy body disease or dementia has some safety issues there too. Again, falls can happen with everybody, but in people with Lewy body dementia, falls can be more of a problem earlier on in the journey because they start to present with balance and gait problems fairly earlier in the illness than people say with Alzheimer's. And also, hallucinations and illusions are fairly common with people who have Lewy body dementia. Hallucinations are seeing and hearing what others cannot see and hear. Illusions are misinterpreting images, and delusions are false beliefs. And I have a great example. This is a piece of floor tile, and when I was looking at it, I thought, damn, this is, horrible. I don't like it. And then I realized why. As I looked at it, I swore I could see almost like a face and the profile of a duck. It was freaky. And people with Lewy body tend to see a lot of images in highly patterned wallpaper and fabrics and floor coverings. So I hope you enjoyed this webinar. What I wanted to talk about as well is I am in the middle of launching the Confident and Competent Dementia Caregiving Program, and it does cover 5 weeks. But the important thing is, I want to make you into your own personal dementia expert. In other words, I want to put me out of a job because I have folks who work with me, who follow the webinars and everything. But ultimately, I want to share a lot of knowledge so that you understand what's going on with your loved one and you can get in front of the behaviors and handle them in a confident and competent way. So the first week is I talk about the different types of dementia. I provide the foundation, and each session has this type of didactic content, and then it has the group coaching and the live Q&A. Week 2, I really drill down into care refusal behavior. And I'm also going to add in what to do when the person living with dementia only wants you to take care of them. And again, the group coaching. And then week 3, and all these are Wednesdays, 6 to 7:30 Central. I go deep into safety issues, and week 4, I go into some other behavioral issues like sexual behavior, shadowing, sundowning. And then the final piece is medication used in the dementia journey. And I also talk about what to do towards the end of the journey. What is palliative care? How to evaluate a memory care facility, getting in-home help. And but the thing that I'm really super proud about is I like the bonuses. And one of the concerns I hear from people is, yeah, this seems like a great program, but I've tried stuff before and maybe everybody else can do it. I don't think I can. I don't think I can do this. And I have seen so many caregivers, even the ones I work with one-on-one or the people I work with in the clinic. I have watched transformations happen before my eyes. The problem with the clinic is I only see people every 6 months. So it takes about 3 or 4 visits, and then the transformation happens. If I had worked with them one-on-one earlier in the process, I think I could have gotten them, I could have saved them 4 years of trial and error. So the 2 30-minute private coaching calls is my way to help work with you. What do you see as your challenges? What's holding you back? What are the behaviors? How can I give you a head start so you can jump into this program and blaze through and succeed? So I like to have one in the beginning and then one toward the end. Like, okay, you've heard all of this stuff, you've worked on all of this stuff. What's next? I also have a bonus video, Dementia Cures, Fact, Fraud, and Fiction. The webinars are recorded and posted. You get a lifetime membership in the closed Make Dementia Be Facebook book page. And I do monthly Q&As there. I'm doing one on Monday. And I upload all of this information. I record it. You have separate audio and video files. You also get a 25% discount on future one-on-one packages. And the other thing I have decided to do, I was thinking about it today because I'm thinking, how can I really make this a super successful program for the people who join? And that is, I've decided to do 2 more bonuses. One, I'm going to put all of the slides together in PDF like workbooks and put in things that you can do. I don't want to say homework, but action plans. What are you going to do this week? And let's talk about it. Because I realize when I'm in programs that help me do marketing or help me podcast, the best programs have content and then they give me stuff to do. I get homework. Like for the next week, do this and this. And I thought that would help people in the program. And the last bonus that I am going to add is there's something called Voxer. I've used it with coaches that I've hired. And Voxer is, I call it a walkie-talkie app. It's a free app for your smartphone. And it's a way for you to communicate with me. And so what you would do is you would go into Voxer and look me up. And then you would push the microphone and you'd say, hey, Rita, this is the problem I'm having. And you would describe whatever's going on. I listen to it and I respond. So it's very much like a recorded walkie-talkie conversation. And that's nice because I like doing it because I'm always thinking, what if my coach is in the middle of something? And it's a really cool way to communicate. And I think having that type of access in between the webinars and then for 6 weeks after the course, I think would really help people use the strategies, tweak the strategies, and make themselves their own dementia behavior expert for their loved one.